Alright, welcome to part 6, and we're going to talk about how to rate control. We just talked about how to decide whether to provide rhythm control or rate control. Now let's talk about the specific drugs you can use for acutely controlling the rate in a patient with Afib with RVR, also known as fast Afib. So you've got a patient with fast Afib, and you need to slow the rate. What are your choices? Your traditional go-to agents are either the non-dihydropyridine calcium channel blockers or beta blockers. In a patient without heart failure or asthma, you can choose either class since there isn't a clear-cut advantage of one versus the other in most cases. So let's go ahead and start with the calcium channel blockers. It's important to note that since your goal is to decrease the heart rate, you're going to have to use a non-dihydropyridine calcium channel blocker, which limits your choices to either diltiazem or verapamil. Why can't you use a dihydropyridine calcium channel blocker like amlodipine or nicardipine? That's because the dihydropyridine calcium channel blocker's site of action is limited to the vasculature and ultimately leads to vasodilation. And this vasodilation in some cases can actually cause a compensatory tachycardia. Now the dihydropyridines don't have any effect in the myocardial cells. Here's how the non-dihydropyridines work for you. So this is Willie, your myocardial cell. The non-dihydropyridines work by inhibiting the L-type calcium channel. So this is your L-type calcium channel right here on the myocardial cell. So you're going to have calcium that flows down through this channel, and it's going to trigger the release. It's going to come down, activate the sarcoplasmic reticulum, trigger the sarcoplasmic reticulum to release calcium. And this creates what's known as calcium-induced calcium release. Now this calcium goes on to interact with the troponin myosin complexes and ultimately leads to the myocardial contraction. So in the normal cell, you have calcium that comes through the L-type calcium channel, hits the sarcoplasmic reticulum, which releases calcium, which triggers contraction. So with the non-dihydropyridine calcium channel blockers, verapamil and diltiazem, they basically put a cork in this L-type calcium channel. So you have a dramatic decrease in the amount of calcium that's able to enter the cell. So without that calcium influx through the cell, the sarcoplasmic reticulum can't release as much calcium, and so the overall force of contraction is going to decrease. And so will your rate. So it has a negative inotropic and a negative chronotropic effect. And since the dihydropyridine calcium channel blocker, so all of your others, amlodipine, nicardipine, any other pines, those don't work in the myocardial cells. They only work in the peripheral vasculature. So this is also the reason why you don't want to use the non-dihydropyridines in heart failure. So if you're decreasing that calcium influx and you're decreasing the release from the sarcoplasmic reticulum, you're going to decrease that force of contraction, so negative inotropy. And if you have a patient with heart failure that already has decreased cardiac output, you don't want to take away that drive anymore. So that's the primary reason why we stay away from non-dihydropyridine calcium channel blockers in heart failure. Okay, so let's go back to our flow sheet. So we're going to talk about the non-dihydropyridine calcium channel blockers first. Now, and you can use either diltiazem or verapamil, but just based on clinical practice, diltiazem seems like it's used 9.999 times out of 10. In all honesty, I don't know that I've ever used verapamil clinically for acute rate control in an Afib patient. So diltiazem, what you're going to do, you have a patient that presents with Afib with RVR, so their heart rate is elevated. We're going to start off with 0.25 milligrams per kilogram. We're going to give it IV over 2 minutes. And it's important to give it over 2 minutes. You don't want to give it too quickly, because if you give it too quickly, you can precipitate hypotension pretty rapidly. So you want to make sure that the dose goes in over 2 minutes. Your average first dose is going to be roughly 20 milligrams. If you don't have any response from that, then you can give 0.35 milligrams per kilogram, which is an average of about 25. You give that IV again over 2 minutes, and then at that point you need to start an infusion after. Normal starting dose is 5 milligrams an hour, and you can titrate that to response with a max rate of 15 milligrams per hour. In between the two bolus doses, we'll normally wait about 5 to 10 minutes to see what type of effect we have. And if we don't have that adequate effect, then we'll go ahead and give the second bolus dose. But we're going to start the infusion behind pretty much regardless, because we want to maintain that decrease in heart rate. If your patient's borderline hypotensive, then you can start with a lower dose. You don't have to start with 0.25 and 0.35 each time. So sometimes we'll start with 5 to 10 milligram bolus, and then we can follow that up with a 10 to 15 milligram bolus, and we may start the infusion at 2.5 milligrams. So it's very clinically dependent. You just have to treat based on what the patient is presenting with. And if the patient's hypotensive, their pressure's labile, if you're worried about them becoming hypotensive, you don't necessarily want to slam them with the full dose right up front. So we can start low and go slow and use that old adage. So just, again, treat the patient based on the patient. Don't do it just based purely on what the book will say about dosing. So there's going to be a little bit of flexibility within there. Now, if you choose to use verapamil, One thing about Verapamil before I get started is Verapamil is the most lipophilic of the calcium channel blockers. It's going to have a very rapid onset, but there's also an increased risk of adverse effects, and it's going to have a more pronounced blood pressure lowering effect. So if you have a hypotensive patient from the get-go, Verapamil may not be a great choice to use. If you do use it, then start with 2.5 to 5 milligrams and give that over 2 minutes again. So 2 minutes is kind of the average time frame to give an IV dose over, and that's going to help avoid hypotension. If you don't have any response after about 20 to 30 minutes, you can repeat the bolus, and then you're going to follow up with an infusion at 2.5 to 10 milligrams per hour. And your starting dose, again, is just going to be based on what the patient is showing you. You walk into the room, what does the patient look like? What does their blood pressure look like? What's their heart rate? If their heart rate is 115 and they had a good response with the IV bolus, you don't need to start them at 10 milligrams per hour. 2.5 would probably be fine. If their heart rate's 180 and their pressure's good, then you may start it at 5 to 10 milligrams per hour. So again, it's just very clinically dependent. And in both of these cases, you want to transition to oral therapy as soon as you're able. So as soon as the heart rate gets under control, they're stabilized, their blood pressure's stable, they're going to need to be transitioned to oral therapy. Typically, this is going to happen in the inpatient setting. We usually don't start maintenance oral therapy down in the emergency department, but just know that at some point, sooner rather than later, you need to put them on oral meds. In terms of which oral dose to use on these meds, I would just refer to Dr. Odom's lecture in Oral Antihypertensives and just follow the guidelines that she put forth. All right, now let's go back to our patient. Now let's say that that this guy has a history of heart failure, but he's not acutely decompensated, so it's not an acute exacerbation. In this case, beta blockers are going to be okay to use. And I can't remember if I said it at the beginning or not, but in the absence of heart failure, beta blockers and calcium channel blockers are pretty much equally effective, so you can pick whichever class you feel most comfortable with. But here, beta blockers, the most common beta blockers that we'll use are either esmolol or metoprolol. You could technically use labetalol as well, but I'm a little hesitant to use in these situations because you're limited to a maximum daily dose of 300 milligrams of IV labetalol, and as you get close to this limit, the duration of action is going to extend out to almost 20 hours. And this isn't a good thing if you accidentally precipitate hypotension because it's going to be really difficult to fix that problem. So again, based on clinical experience, we usually stay with either esmolol or metoprolol. Other institutions may use different agents, but in the practice that I've been involved with and the patients that I've seen, these are our two favorite drugs to use. If you use esmolol, your dose is going to be 500 mics per kilo over 1 minute, or you can say 0.5 milligram per kilogram. Whichever way is easier for you to remember. Immediately after that, we're going to start an infusion at 50 mics per kilo per minute, and we're going to run that over 4 minutes. And then at the end of that 4 minutes, we're going to reassess the patient. If we're happy with the heart rate lowering we've seen so far, then we can continue the infusion. If we're not that happy, so if the heart rate hasn't dropped noticeably at all, there isn't a set guideline for how far the heart rate has to drop before you make that judgment of whether or not you're seeing success. Most things are going to be clinically dependent, so just look at the patient and see what you think. If they start off with a heart rate of 180 and the heart rate drops to 170, it's not going to be a great amount of lowering. You want to see it a little bit lower than that. If it starts at 180 and it drops to 140, 130, then you're seeing pretty good activity with that initial bolus and infusion. So I would just continue at that point, and we could titrate the drip up if we needed. But if we're not happy with the amount of heart rate lowering that we've seen, then we can rebolus the patient with another 500 mics per kilo, and then we're going to titrate that infusion up to effect. And typically we'll titrate in increments of 25 to 50 mics per kilo per minute, and we'll do that about every 15 minutes or so. Now, the beautiful thing about esmolol is that it's got a very fast onset, and its duration of action is only about 9 minutes. So this means that if you overshoot their blood pressure and you cause them to go hypotensive, you can basically just shut off the infusion at that point, and their pressure is going to rebound within about 10 minutes or so. The downside to esmolol is that technically you need to give it through a central line, because there's a risk of thrombophlebitis and extravasation. But if you need to give it, you can give it through a large bore IV for a short time. And as a just very general rule of thumb, you should only infuse it through an 18 to 20 gauge IV, and it needs to be at the AC fossa or more proximal. Basically what this means is you don't want to give it through a forearm, a hand, a wrist, a foot. It needs to be a large bore vein with large bore IV access, and that's going to decrease or minimize the risk of extravasation in those patients. Just like with calcium channel blockers, you want to transition to oral therapy as soon as it's feasible. Esmolol is not available as an oral drug, so you're going to have to transition them to another beta blocker, and whichever beta blocker you choose is up to you. And when you do transition to oral therapy from esmolol, you're going to have a little bit of overlap. So they're still going to be on the esmolol infusion, and you'll give them that first dose of oral therapy, and then 30 minutes after that is when you'll go ahead and turn off the esmolol drip. So there's going to be 30 minutes of overlap between transitioning to oral and shutting off the drip. The other option you can use is metoprolol. It's got a little bit longer duration of action at about 5 to 8 hours. So you have to be careful not to precipitate hypotension by giving too much too quickly. For acute dosing, you're going to give the patient 2.5 to 5 milligrams over 2 minutes. Again, there's your magic 2-minute number. And you can repeat this bolus dose every 5 to 10 minutes up to a cumulative maximum of 15 milligrams IV. After they get the last dose of metoprolol, go ahead and transition them to an oral beta blocker. Again, using the dosing guidelines outlined by Dr. Odom. Alright, now let's make things a little bit more complicated. What happens when you get the patient, and you will at some point, you get the patient that has fast Afib and acute decompensated heart failure with some pulmonary congestion, we'll say. In this case, you definitely can't use a calcium channel blocker, and you can't use a beta blocker. If you use either of these, you're going to ultimately make the patient worse than better, so try not to make your patients worse than they were when they first came in. So in that case, we're going to go to digoxin. Now, if they don't have any contraindications to digoxin, and really there aren't many absolute contraindications to digoxin, probably the biggest one though is if it's a wide complex tachycardia, which is going to be a little bit more rare to come across in practice. It definitely does happen. I've seen my fair share of wide complex tachycardias in patients. But for the purpose of this lecture, we're just purely talking about Afib with RVR, which is going to be a narrow complex tachycardia. And in a narrow complex tachycardia, we're okay to use digoxin. If used in a patient with wide complex tachycardia, which is typically associated with a pre-excitation syndrome like Wolff-Parkinson-White, if we gave digoxin in that case, then you could precipitate VFib, and that is going to take the patient down a bad pathway. That's the pathway towards pulselessness. So here we're going to say it's a narrow complex tachycardia, and it's Afib with RVR, and there's no obvious contraindications to digoxin. Here we're going to do 0.5 milligram IV times 1, and then we're going to follow that up with 1/4 milligram IV every 6 hours for 2 doses. So you give the first bolus dose, then you wait 6 hours, then we're going to give 0.25 IV, we're going to wait 6 hours, and then we're going to give one more dose of 0.25 IV. And then 6 hours after that, we're going to transition to oral dosing at 0.125 to 0.375 milligrams orally daily. Digoxin provides some rate lowering by inhibiting the AV node to a degree, and it's also a positive inotrope. It's going to increase the amount of intracellular calcium, which is going to increase that calcium-induced calcium release, which is going to cause greater contraction by the heart. So it's good for heart failure. It'll have some help with rate lowering, and it's going to be the best option for the patient with acute decompensated heart failure, since we can't use the beta blockers and calcium channel blockers. The problem with digoxin is that it takes a long time to work. You're going to have a slow onset, sometimes up to 3 hours after an IV dose. And that's a long time to wait when you have a patient that comes in Afib with RVR and a really fast rate. It seems like it takes forever to see that rate start to come down. There are also a lot of drug interactions with digoxin. For example, digoxin plus calcium channel blockers can increase that serum concentration of digoxin by up to 70%. So you have to be very, very careful with that. It accumulates in renal failure, so you have to use caution. If they have any degree of renal failure. You can still use it, you just have to keep a close eye on the serum digoxin levels. So you'd still use a normal loading dose, but then with oral therapy you'd have to adjust the dose based on renal failure. And the other thing is that for long-term management of AFib, it doesn't mitigate the exercise-induced heart rate increases that you'll see. So if you have a patient that sits around on the couch all day, then digoxin is probably going to be an okay option for long-term rate control. But if you have a patient that does any degree of exercise, digoxin on its own is not going to stop that heart rate from increasing. Your goal serum concentration for digoxin is going to be 0.5 to 0.9 nanograms per mil. And with maintenance therapy, you're going to want to check a level within 5 to 7 days of any dose change. And you need to make sure that you're checking a trough, which means that you want to check at least 6 hours after the last dose was given. Or let's say the patient takes digoxin at 6 in the morning. You wouldn't want to check the level any earlier than noon because you're going to have an abnormally high reading in that case. And you also want to monitor the patient's potassium, mag, and serum creatinine, since hypokalemia and hypomagnesemia can precipitate toxicity. So you want to keep a close eye on your potassium and your mag. Serum creatinine is important to keep an eye on because renal failure is going to decrease the rate of excretion of digoxin, so you can increase those serum levels and precipitate dig toxicity, which is something that we'll cover next semester during the toxicology section. And then once the episode of acute decompensated heart failure resolves, it may be appropriate to add a beta blocker for further rate control. So what do you do if you have a patient that for whatever reason you can't use digoxin in? So maybe they do have end-stage renal failure and we're just not comfortable with giving digoxin in that case. So one thing is you always want to look further in advance just beyond that initial point in time. So you want to have an end game in mind. You want to have an end strategy in mind. If you have a patient with end-stage renal failure that comes in, we can technically give a loading dose of IV digoxin to try to get the rate down. But what are we going to do after we get that rate down? It's going to be hard to start them on oral maintenance digoxin in that case because of the renal failure. It's really going to complicate things. So sometimes it just, even though you can use something, it doesn't necessarily make sense to if something on down the line is going to prevent you from carrying out that therapy. So let's say that for whatever reason, we decide to go ahead and use amiodarone. I mentioned in the last video that amiodarone is not a great choice, and it's really not. It's kind of it's a choice of last resort. But if we have to use it here, and we've had to in the past, then what we're going to do is we're going to give 300 milligrams as an IV bolus over 1 hour, and then we're going to follow that up with a continuous infusion between 10 to 50 milligrams per hour over the next 24 hours. And this rate's going to be based on their heart rate and the degree of lowering that we're going to need. After this, we can consider transitioning to oral. If we do usual daily doses between 100 to 200 milligrams, and that's for rate control, so that's a rate controlling dose. Some notes on amiodarone: it's got a very slow onset, even slower than digoxin. It can take up to 7 hours to start to see rate lowering effects, which again is an eternity to wait with a patient with acute AFib with RVR that's tacking away, and in the back of your mind you're wondering if that patient's going to decompensate at some point and go pulseless. So this does take a long time. So you can kind of see why it's not a great option for initial therapy. The other thing is that it could potentially convert the patient to normal sinus rhythm, which is dangerous if the patient has an atrial thrombus, because that can embolize and cause a stroke, which isn't good in any book. But you can take some sort of comfort with amiodarone and knowing that it's not a great rhythm agent either. It's got a rate of conversion of, I want to say roughly 30% patients to normal sinus rhythm. So, you've got a 2 in 3 chance that they're not going to convert to normal sinus rhythm, but that 1/3 of patients, it could precipitate a dangerous scenario. It's also a really dirty drug that requires a lot of monitoring. It can cause pulmonary fibrosis. It can precipitate microcorneal deposits. It is QT prolonging, is hepatotoxic. It's got iodine in it, so it can cause thyroid dysfunction, and it causes a lot of GI upset. So what you need to do is if you continue on with this drug, you're gonna have a lot of monitoring to do, and the patients are gonna have to come in a decent amount to keep up on it. But they're gonna have to get pulmonary function tests, a chest X-ray, and an eye exam at baseline, and they're gonna have to have this done at least annually. They're also going to need an EKG, LFTs, and thyroid panel at baseline, and then every 6 months. You're going to have to educate the patient to wear UVA sunscreen every time they go outside because it increases photosensitivity. And then tell them it's a good idea to take their dose with food, which will help to minimize that GI upset that you'll see. It does, again, prolong QT intervals, so you have to use caution with other QT prolonging drugs. For a list, again, you can go to azcert.org. And just like we mentioned with digoxin, once that acute heart failure exacerbation resolves, we may be able to transition it back over to an oral beta blocker and discontinue the amiodarone. So this brings us to the end of how to rate control a patient. But I should say a couple things that'll help you clinically. The first thing is that if you start with an IV calcium channel blocker and it fails, don't combine it with an IV beta blocker. This is going to lead to additive AV nodal blocking, and if you have additive AV nodal blocking, you're going to really increase the risk of hypotension and bradycardia. In fact, we had a patient that came in at one point with PSVT, had a heart rate in the 200s and a blood pressure that was 220 over 120 roughly. We tried adenosine for the PSVT and it didn't break the SVT, so then we went to IV esmolol, actually, because she was on a beta blocker at home, and we thought we'd just continue it here. The esmolol didn't work, so we went ahead and tried some metoprolol just to see, and just had minimal heart rate lowering with that. So we consulted cardiology. They came down and gave another dose of adenosine, which didn't work. And then they ordered a dose of IV diltiazem. Didn't feel comfortable with that, but cardiology wanted it done, so it worked. It brought the patient's rate down to the low 100s, but the pressure came down to about 80 over 60 within the next 5 minutes, so a precipitous drop in blood pressure, which is a little bit nerve-wracking. We had some calcium on hand to try to reverse the calcium channel blocker effects as best we could if we needed to, but luckily she stabilized over the next few hours and didn't need it. But if her pressure hadn't been that high from the get-go, it could have ended a lot differently. So again, don't combine IV beta blockers with IV calcium channel blockers. I mentioned when we were talking about diltiazem, if your patient's hypotensive, you can start with lower doses. And this is true across beta blockers and calcium channel blockers. So just work with what the patient's showing you. So instead of starting with the diltiazem 20 milligram bolus, you can start with the 10 and then start the drip at 2.5. You can give them a 5 milligram bolus and start at 2.5. It's very, very clinically dependent. There's no black and white answer in terms of what dose to start at when. It's based on Gestalt and what you see over time. If your patient doesn't have heart failure, you can use either the non-dihydropyridine calcium channel blockers. So again, non-dihydropyridine. You have to use non-dihydropyridine. Dihydropyridines aren't going to do anything for you. Or you can use your IV beta blockers. Both are effective. If the patient with heart failure is currently decompensated, use Digoxin. And if your patient has asthma, calcium channel blocker is going to be preferred. But it's okay to use beta blockers if they have COPD. So the greatest risk with beta blockers is using it in bronchospastic disease, and COPD isn't really considered a bronchospastic disease. So beta blockers are okay to use for COPD. Some other things you'll want to think about, again mentioning the end game, having the end game in mind. If the patient has a history of ischemic heart disease, you may want to go ahead with a beta blocker, since they've been associated with reductions in the incidence of ventricular arrhythmias and sudden cardiac death in this patient population. So again, think ahead, think of what other disease states they have, which drug is going to be most beneficial for them to continue on a long-term basis, and whatever that drug is, as long as there's no current contraindications, then that's the drug in the class that I'd recommend. So now that we've covered the rate-controlling agents, let's go ahead and move on to part 7, and we're going to talk about how to assess the stroke risk in your patient.